I will give you my own personal opinion, as you will see along. Also, I will try to refer to scientific evidence as much as possible. So what we will talk about today, this is the overview. Start with the introduction. If you're not using opioids, you might go for an early lunch, because that's what we will be talking about today. Personally, I use sufentanil and remifentanil. Most of the time, I use inhaled anesthesia, and we almost always use it in a target-controlled fashion. So today we will talk about the Dräger SmartPilot View. In this lecture, I will mention SmartPilot, I will mention SPV, it's all the same thing. In our hospital, we have 20 operating rooms and we have SPV in 2 rooms. For the sake of this lecture, if you're a fentanyl user, let's say, it's not completely true, but let's say if you multiply the micrograms of sufentanil by 10, you have the micrograms of fentanyl. So let's start with a letter that I received from a patient. Dear doctor, I recently had anesthesia 2 times. The first time, I woke up in the recovery room and I was very anxious, confused, shaking, and I felt a lot of pain. Second time, when you were my anesthesiologist, I woke up very comfortably. I felt no pain and I was well orientated the moment I opened my eyes in the operating room. Now I need surgery again, and I want to ask if you could be my anesthesiologist once more. So that's why I went to review both files. This is what it shows. So there's of course a difference in the duration of the operation, but that's not in our hands. Otherwise, there's also a few other differences. So I gave a little bit more opioids, and I gave a whole lot less of inhaled anesthetic. And there's something else. I used a device called SmartPilot View. Why did I use SmartPilot View? Because I want to give balanced anesthesia. I want to combine drugs in order to use less of each drug and to reduce the likelihood of side effects, like, for example, hypotension. I want to decrease waste. Sustainability is a hot topic nowadays. I want an early recovery for my patients, and if possible, I want to increase patient satisfaction. There's a lot of evidence about all these things right now that they are very important for our patients. So this is an example that shows that SmartPilot View is helping us to give balanced anesthesia. If you use SmartPilot View, you have a shorter extubation time, mean arterial pressure is higher, and the propofol consumption is lower. However, evidence is scarce. I found, and this is a very recent search, I found only 6 results talking about SmartPilot View. So we will have to look at some, what I call circumstantial evidence. We will have to look on articles talking about pharmacology and how it can help us to optimize anesthetic drug administration. It shows that a low opioid dose, like remifentanil effect site concentration of 1.3, allows us to reduce our sevoflurane or propofol dose by almost 50%. That's a huge dose reduction. This is called synergy. We will elaborate on synergy a little bit more. I will tell you about how it is represented. There's also a number for synergy, and we can use a display. If we talk about pharmacology, we have to be careful. Pharmacology is giving you a prediction, and pharmacology is talking about the population. So it's not the same as a prediction, is not the same as a measurement, and a population is not the same as our individual patients. So keep that in mind. So synergy can be graphically represented on a dose-response surface. That is a 3D graph with on 2 axes the opioid and the hypnotic, and on the third axis you have the clinical effect. Oh, I'm sorry. Yeah. Should I repeat it? No. Okay. So on the third axis we have the clinical effect. For anesthesia, we are typically interested in an effect that is no effect. So the effect that we want is no response. For example, here we have no response to intubation. So you may notice these lines, the yellow, the red and the green line, they are called isoballs. An isoball is a line combining points that all have the same probability of a certain effect. This is a quite complicated graph. It's not easy to handle, but if you look from the top down on this graph, it will become a two-dimensional graph, like the one you see here. So you have on the x-axis the opioid concentration, on the y-axis you have the hypnotic concentration, in here it's sevoflurane, and you have the isoballs. Now each point on the yellow isoball, that is called the 95% isoball, will give you a combination of effect site concentrations that gives in a population 95% of the clinically effect. So this effect will be not moving. So you can have the clinical effect with a high opioid concentration. Oh, no, you don't see it. Like, for example, 9 nanograms per milliliter remifentanil and less than 1% entitled sevoflurane, or you can have the same clinical effect with almost no remifentanil and 2% of sevoflurane. This is already easier to handle, but we can even make it more easy, and we can make it one-dimensional. We can make it a number. That number is called the noxious stimulation response index. It's a number going from 100 to 0, where 100 gives you a high probability that the patient is awake, and below 20 gives you a high probability that the patient will not move to painful stimulation. This number works. This is a study that is done, and they have compared the noxious stimulation response index to other variables like sevoflurane effect site concentration, remifentanil effect site concentration, and measurements like, for example, the BIS. And they compared them to see how well they did in predicting response to certain stimuli, like their shake and shout, tetanic stimulation, laryngeal mask insertion, and laryngoscopy. And it proved that the NSRI was better in predicting movement or no movement compared to the BIS. So this is all good, but now we have to make it usable in a clinical situation. In the operating room, where we don't have time to calculate everything, where we don't have time to do those difficult math, and that's when SmartPilot View comes into play. So SmartPilot View is a software running on a screen that is connected to your anesthesia machine. Over here it's connected to an older version of the Zeus. Can also be connected to other Dräger anesthesia machines like Atlan, Perseus, or Primus. In newer versions of Zeus, it's incorporated in the screen, but we will see that later. Now let's have a look at all the information that is on that screen. First, on the top left, we have the patient characteristics. So these are all important variables to calculate the pharmacology, and we have entered them manually in our system. Next, we have our calculated effect site concentrations. These come from different sources. First, we have drugs that we give as a bolus, and then we have to enter them manually into the system. Then we have, like we see here, the entitled concentration of our inhaled anesthetic. This comes from the anesthesia workstation because the SmartPilot View is connected to your anesthesia machine. If you were to use syringe drivers, they would also be connected to your SmartPilot View, and then you will have their information also transmitted to the screen of the SmartPilot View. Next, we have our two-dimensional dose-response surface graph that we have discussed already. So you can see that it shows the course of our anesthesiology so far, and then now we are at the orange dot. In 10 minutes we will be the black dot, and in 50 minutes we will be the white arrow if we don't change anything. So if we don't give an extra bolus of a drug, or if we don't change the entitled anesthetic concentration. You may notice here that we have, the isoballs have a name. They have a MAC 90 isoball, that is the highest up. Then we have the MAC 50, and then we have TOS 90 and 50, where TOS stands for tolerance of shake and shout. Next, we have our noxious stimulus response index, the number that we talked about. It is 20, so we are good right now. Very important a very important aspect of the SmartPilot View is that you have information, that you have a prediction that goes 20 minutes in the future. So it gives you an idea where you will be in 20 minutes if you don't change anything. This has a lot of benefits. It helps you to plan. It helps you to calculate if you would need to give an extra dose, or if you would do anything else to make sure that your patient does not sleep too long at the end of the surgery. So if you have a new Zeus, then SmartPilot View is on the split screen. There's a little button on the right. If you tap that, then on the left, SmartPilot View comes up, and again you have all the information that we had on the big screen. So you have the patient characteristics, you have your calculated effect site concentrations, you have your dose response surface graph, and you have your NSRI. So this display immediately allows us to have a graphical and understandable view of pharmacology. For example, it shows us additivity. As you can see here, all the hypnotics are on the y-axis and they just all add up. We have our opioid on the x-axis, and we have our graph showing synergy. If there would be no synergy, we would have a straight line. Yeah, I tried to show it, but the pointer is not really working. We would just have a straight line like that. Because the curve is bent, that is the clinical representation of synergy. We have a what-if function on SmartPilot View. So if we would, let's say we would give an extra dose of sufentanil. Before we confirm the dose, the SmartPilot View already shows us where we would be in 20 minutes if we would confirm and really give that dose. So this allows us to see, before we give the dose, what would be the predicted effect of that dose. So when would SmartPilot View be useful? It would help us to give or not give an extra dose of opioids. It would help us to decrease our hypnotic drugs. And it would help us to steer us how much we can do that. It would help us to answer the question, how come my patient is not waking up and my entitle is already 0? How come my patient is still moving and my entitle is 1.3 MAC? How come? There are other examples, of course, that I will be happy to discuss with you, but we have to stick to the time. So let's start with a very basic anesthesia. We start with a bolus of opioid. So I have on the left, I have sufentanil, on the right, I have fentanyl, and we give 50 micrograms of sufentanil, and we give 150 micrograms of fentanyl. We can see a lot of things already. So first, if you only give opioid, there is no question of synergy. So we will just stay on this x-axis, and we will never be even close to the isoballs. So no matter how much opioid you give, you will never reach TOS. Your patient will die for sure, but you will never reach tolerance of shake and shout. Second, but this hasn't got to do with the opioids. Over here I have the isoballs for sevoflurane. Over here I have the isoballs for propofol. And you may notice the difference. That is because there is a different pharmacology for inhaled anesthetics and for propofol. For inhaled anesthetic, you have a very steep dose response curve, while for propofol, there is a much bigger variability. Next, we are going to give some propofol, and SmartPilot View helps us to see when we should give our propofol. If we give our fentanyl or sufentanil, and immediately after that we give the propofol, then we will need a huge dose of propofol to get us above the toll 90 isoball. If we wait like 4 or 5 minutes, then our opioid, fentanyl, sufentanil, has reached its peak effect, and the dose required of propofol is much lower. So this is a graphical illustration of the time to peak. So we are going to give some propofol, and immediately you see that in 10 minutes we will have a problem, because we will dive under the toll 90 isoball again. So we will have to do something. SmartPilot View shows us that we can easily give an extra dose of opioid, and in 10 to 15 minutes we will be more or less at the same situation again. So this helps me convince colleagues that only give fentanyl or sufentanil every hour or so. So these drugs have a very short action, and they should be given regularly. How much can I reduce my dose of inhaled anesthetic? This is a study we did in our hospital, where we were literally surfing down the isoball. We started with 1.3 Mac, and we went all the way down to 0.6 Mac. We adjusted the opioid concentration accordingly to stay above the isoball. So over here we have like almost around 1 nanograms per milliliter remifentanil, and here we have 5 nanograms per milliliter remifentanil effect site concentration. And this study shows you that the BIS in all 3 groups remain between 40 and 60. So it's safe if you use synergy to reduce your hypnotic concentration with 50%, as we have seen from the article earlier on. For inhaled anesthetics, the central nervous system is the effect site. So end-tidal concentration is not effect site concentration. This is important in the beginning and at the end of anesthesia, where they're not the same and where there is still equilibration going on. This is an explanation why, even if you have an end-tidal concentration of 1.3 Mac at the beginning of anesthesia and your patient is still moving, it does not mean that your inhaled anesthetic concentration is not enough. It means that your inhaled anesthetic concentration is not at the desired level in your brain already. The same is true at the end of the operation. When you turn off the vaporizer, end-tidal concentration quickly becomes 0 or close to 0, and your patient is not waking up. That's because Your inhaled anesthetic is still in the brain, and it needs time to equilibrate. This thing is called in pharmacology hysteresis, and it is shown here. So you see the white line is the end-tidal concentration, and the blue line is the effect site concentration or central nervous system concentration. This is for desflurane, where the difference is not so big, but for sevoflurane, that is more, the difference is even greater because it has a higher solubility. Unfortunately, we cannot always use SmartPilot View. The device will give us an incorrect prediction if we give pre-medication, if we give other drugs like benzodiazepines, if we use local regional anesthetic technique, or if we err in the manual data input. So, for example, if we say that we give 100 milligrams of propofol, but in reality we have given 200 milligrams, or if we say that the patient is 70 years old, but it is 40 years old. There's also limitations in the patient demographics. So we cannot do kids, we cannot do patients with morbid obesity, and if you have underlying disease, the prediction becomes more and more unreliable. In my opinion, there's also room for improvement, because nowadays there are new interaction models, for example, like with dexmedetomidine, and we also have, for the opioids and propofol, we have new TCI models, like, for example, Eleveld, where we can incorporate morbidly obese patients, and more of our patients are morbidly obese right now. So I have to warn you about the thing, and this thing is patient variability. So SmartPilot View gives you a prediction based on studies done mostly in healthy volunteers. So if the prediction gives you this in a healthy volunteer, it will be more or less this in a patient. Even so, if you go to the extremes of the graphs, where there are less and less data and there's more extrapolation, it will be like this. So that's why we have always to keep in mind SPV, SmartPilot View, is not a monitor. It's a tool that helps us to predict, and it works for the population. So if it says 90% of your patients will move, it does not give you any information about a single individual patient that you're treating right now. It is a prediction, it is different from a measurement, like, for example, EEG. And that is why, in my daily practice, I always combine them. I use SmartPilot View to predict, and I use EEG to check if my patient is one of those 90 or if it's an outlier. So in conclusion, how do I suggest that you start working with SmartPilot View? First, just don't do anything other than you do normally, but enter the data in SmartPilot View and see where you are on the screen. That will already be a revelation. It was for me 15 years ago. Then I suggest you combine SmartPilot View and the point on the screen where you are with depth of anesthesia monitors. For sure, if you're high above the 90% isobol, your EEG monitor will show you that you have too deep anesthesia. And then, with the combination, you can start fine-tuning. You can improve hemodynamic stability. You will need no phenylephrine anymore. You can aim for faster awakening. You can titrate your opioids better, and you will have a reduced drug consumption. So after 15 years of using SmartPilot View, with all the knowledge I got through it, I don't need it anymore, but I want to keep it because it interests me, and I want to use it for teaching and demonstrating pharmacology to our residents, and also I hope that I will be able to experience new models and drugs with it. Thank you for your attention, and I'm ready now for a whole lot of questions.